Now, folks online, please do ask questions because we're going to have a panel discussion for Margaret, Devi, and Maria in about 20 minutes' time. But that gives me a fantastic segue into welcoming Maria van Kerkhove. So welcome, Maria. It's a huge pleasure and a privilege, and thank you for agreeing to do our keynote presentation today, Maria. You're a very familiar face to everyone in the UK from the WHO news briefings, and I don't know how many of those you've done, but it's very many. You've got strong ties to the UK, but on behalf of us all in the UK, can we just thank you for everything you've been doing over the last 16 months on behalf of global public health, because it's been fantastic. But it's a huge pleasure to welcome you, and I'll pass over to you now to talk about COVID-19 global policy insights. So Maria, you're very welcome.
Thank you so much for that really nice welcome and for those kind words. It's deeply, deeply appreciated. And all of us here at WHO, thank you for what you're doing as well. And I just wanted to also echo an excellent presentation by Margaret before, the importance of long COVID and for recognition, for research, for rehab. This is something that WHO takes very seriously, and there's a lot more work to do. So thanks for that great presentation. And so I'm going to spend the next few minutes giving you sort of an overview of what we're doing related to the COVID-19 pandemic, where we are in the global situation. Sorry, I have to open up my clicker to make sure that moves. Oh, good. So here's an overview of the global epidemiologic situation since the beginning of the pandemic and the current situation now. Fortunately, at the global level, we are seeing declining deaths over the last several weeks, but this really masks heterogeneity that we see by region, by country, and within country. And there is significant variation in the intensity of spread around the world. So far, what we know, there have been more than 178 million confirmed cases reported to WHO and more than 3.8 million deaths. And this is absolutely an underestimate of the true burden of cases and deaths to date. What you can see on the left-hand side there are some of the early actions of WHO. WHO is often accused of being slow and bureaucratic. And of course, we can be, and we can always be faster. But some of our earliest actions were really about releasing information to get countries ready, to put information out there about who to test, how to keep yourself safe by caring for patients with severe acute respiratory infection, how to collect the right samples, and to get your risk communication and community engagement activated. The Director General issued a public health emergency of international concern on the 30th of January when there were less than 100 cases reported outside of China. And this is our highest level of alert under international law. And the critical part of this is that this is an alert that comes out before you reach the level of a pandemic, so that you're raising the alarm so that countries actually take this seriously and take the steps to prevent something from happening. We issued guidance package. We released a PCR assay through our partner lab at Charité University in Berlin. And within 4 days of issuing a public health emergency of international concern, issued the first strategic preparedness and response plan. But as I said, the regional trends are very different. And this also masks the differences by country and within country. And so you can see some diversity in the trends right now. We are seeing increases and dramatic increases in our in Africa. It's driven by not just South Africa, but a number of countries across the continent in terms of seeing sharp increases in recent weeks, fueled by a number of factors, and I'll come to this in a moment. In Europe, we're seeing a sharp decline. We're seeing declines in Southeast Asia, largely driven by declines in India. But again, we see hotspots in all regions of the world. South America is really experiencing incredibly intense transmission across South America. We see increases in Afghanistan and Iraq and Iran. We see increases in DRC, in Namibia. I could go on and on, but every region has hotspots. Unfortunately, this is far from over. Some concerns that we have are the variants are of concern. The SARS-CoV-2 virus is evolving. It's evolving naturally. This is expected. We have expected this from the beginning. We now have 4 global variants of concern that we're tracking: the alpha, beta, gamma, and delta. The delta variant, the B1617.2, is one that was identified, recently characterized as a variant of concern several weeks ago, and has increased transmissibility, and it's more transmissible than the alpha variant, which is the B117. These graphs show you the geographic distribution of detection of the variants of concern, which is limited by our ability to have eyes and ears around the world in terms of sequencing, the sharing of metadata in addition to that sequencing, so that we can analyze and understand the circulation, we can understand the phenotypic impacts and characteristics of these variants. We issue updates every Tuesday evening on variants of concern. The most recent one last night, which is a deep dive into what we understand about the variants. The Delta variant is of concern. All of them are, in fact, in terms of increased transmissibility. There is a suggestion from data from Scotland of increased hospitalization. We need more information on this to really understand what this is due to. We have not yet seen any increase in mortality due to the Delta variant. But remember, if you have increased transmission, you will have increased numbers of cases, you will have increased hospitalizations, you will have increased burden on already overburdened healthcare systems, which could result in increased deaths. So there's a domino effect here. And in a world that is exhausted, including myself, 18 months into a global pandemic, we have a fatigue that's happening. If you combine the variants of concern with increased social mixing, with the inappropriate use of public health and social measures, and I do not mean lockdown when I say public health and social measures, it's a combination of individual level and societal interventions, plus uneven and inequitable vaccine distribution, that's an incredibly dangerous situation to be in. So let's look at population level immunity. There's different ways that we monitor this. One is through natural infection. And let me be very clear, our goal has always been to prevent infections because we have the tools at hand that can prevent infections. And as you just heard from the previous speaker, there's so much we're learning about this virus in terms of the long-term effects. We don't have a full grasp on this yet. But in terms of the natural infection, it's measured by seroprevalence. We have a global program of looking at standardization around seroprevalence studies through our Unity studies, and we recently linked up with SeroTracker to be able to display this around the world. There's varying levels of seroprevalence around the world, with the lowest seroprevalence in the Asia region, the Pacific region, with around less than 1% of individuals with evidence of seroprevalence. Now, I should caveat this by saying there are more than 1,800 publications, peer reviews, preprints, government reports on seroprevalence, which is a triumph, I have to say, scientifically, to be able to have that. But they vary in quality, they vary in the assays that were used, they vary in the timing of the sample collection, the population under study. So it is, in fact, difficult to kind of compare. And this is why we've launched this Unity study, to be able to have a standardized approach so that we can have regional, global estimates by specific population, health workers, by age, and we're hoping to have some results from this work soon. But if we look at vaccine distribution, it is grotesquely unfair. Of the more than 2.6 billion doses that have been administered to date, less than 1% have been administered in low-income countries. In fact, it's less than 0.3%. Through our COVAX facility, we're trying to change that. And we're very, very grateful for all of the countries, including the UK, who have donated vaccines, who have provided funding to support this. But we need those doses now. We really need those doses to reach those who are most at risk for severe disease and death, those over the age of 60 and have underlying conditions, and those who are our frontline workers. And this is not happening yet. So a lot of work needs to be done in this space to be able to have more equitable vaccine distribution. So we launched our global strategy on February 4th, 2020, with the goals of suppressing transmission, protecting the vulnerable, and saving lives. And this is a combination of mitigation, control measures, and mitigation. There was this false dichotomy in the beginning that it had to be one or the other. Either you try to control or you try to mitigate. And in fact, in this case, it's both. with ultimately trying to prevent infections and save lives. We've updated this guidance over the course of the last 18 months. These were the original goals of our strategic objectives listed here on all of government, all of society, mobilizing every sector. This has always been beyond health. And governments who had experience with similar infections like MERS coronavirus, like avian influenza, like SARS, like Ebola, like meningitis, like yellow fever, really used that experience of dealing with infectious diseases to build a public health infrastructure, and knowing immediately how important this was to activate and really be aggressive about controlling initial cases and sporadic cases to prevent them from expanding into community transmission, making sure that you mobilize your community, you engage, you enable, you empower your communities to be part of this fight. I say a lot that everybody has a role to play, and I fully believe that every single one of us around the world is a leader in this and really must be a leader in showing what we can do to keep ourselves safe and our loved ones safe. And of course, always part of the strategy is to develop safe and effective vaccines. This began before SARS-CoV-2. It began with SARS. It began with MERS through our R&D blueprint for epidemics, with partnerships, with collaborations. And I have spent many trips with Sarah Gilbert in Saudi Arabia looking at MERS coronavirus vaccines for humans and for camels. And so this doesn't happen overnight. This happens through collaboration and dedication by many around the world. In 2021, we added an additional pillar, which is vaccination. It's not just vaccines, it's vaccination. And working with countries to develop national vaccine deployment plans, to implement those, to be ready once those vaccines actually reach the country so that they can be delivered very quickly. But the plan hasn't changed. We've just added additional tools to our toolkit. One of my major roles in this pandemic is translating evidence into knowledge and action. You mentioned me being on these press conferences, and actually I don't know how many we've done, maybe 150 or so. And that was never, ever part of the plan. Never. I was never going to be a forward-facing person. It is not something that I have trained for. I am so privileged and honored to have that role. I do my best. I don't always get it right, but I try to speak openly, honestly, with humility. And science changes. Science evolves. Science grows. And that's a strength. That's not a weakness. Science has always driven our understanding. It's driven our guidance. It's driven our actions. But we need to translate science and that knowledge into coordinated action using the appropriate methods. And so we work with thousands of scientists around the world, translating this into evidence, into this know-how, into how to. These are some of the early actions and advice that I mentioned that we issued within 2 weeks of learning of the cluster of pneumonia. And even in the earliest stages, we were talking about acute respiratory infections with epidemic and pandemic potential. There's a lot of discussion around this, and I welcome that discussion. I welcome that constructive criticism of how we can do better, but I hope that is constructive. How do we be better, be quicker, and how do we use what we know to actually prevent the worst from happening? Because unfortunately, this will not be the last pandemic that we will have to deal with. I hope I'm wrong, and I hope someone will prove me wrong and the world will prove me wrong, but we need to be prepared. This is the pathway of how we turn knowledge into guidance, into practice, starting with evidence generation, which is from multiple studies, multiple disciplines, from epi to aerobiology to engineering to architecture to clinical management to IPC, et cetera, to generate the evidence that we have so that we can synthesize the evidence. Not all studies are of equal quality. Just because it's published in a high impact journal doesn't actually mean it's good science, unfortunately, and I'm sorry to say, but they need to be critically appraised. And we do this through our science division, through our health emergencies programs teams, through groups that we work with to help do meta-analyses and systematic reviews, and through our guideline development groups. Once we appraise the evidence, we formulate recommendations through our guideline development groups, through our expert networks, and this is supported by the WHO Secretariat. We don't have a few people that sit around a table that write recommendations. We work with scientists around the world who have their conflicts of interest checked, who have experience. We work with patient groups. We work with CSOs. We work with many different groups to be able to formulate those recommendations, and then we review them internally at WHO as well as externally through different groups. And then the process starts all over again. Every time we issue a guidance, it needs to be updated almost immediately because the science is rapidly changing, and we're really grateful to everyone out there who's conducting good research, who's sharing that information with WHO, often before publication, and so that we can make the evidence most applicable in all situations. The way that we disseminate this information is in a variety of ways. We are mainly speaking to our member states and through decision makers who are setting the policies. And there's a difference between recommendations and guidance and policies that are set by countries. They're translated, they're turned into trainings. We have help desks. We use our EpiWin platform, the WHO Information Network for Epidemics, to work with different sectors and patient groups and youth groups and religious groups. We have social media, which has been an explosion of COVID-19 individuals looking for information. And then, of course, we use our press briefings. But no one mechanism distributes and disseminates our information product. And we learn from that feedback mechanism. We have emergency guidelines, which are narrow in scope and have a very short shelf life because they have to be updated regularly. But the development of emergency guidance or interim guidance doesn't change the process. It doesn't change the caliber by which we develop them. We just speed up the process to do that. And so it's a challenge. We have a large number, well, not really that many people. We need more to be able to help us do this because we have a large number of guidance that's online. Just clicking through some of these quickly, these are just some maps showing who we're working with and how we're trying to get more input from people all over the world. The pandemic has really changed this, given that everything is an online platform. Everything uses Teams and Zoom and different platforms. We're able to reach more people around the world. However, we are, of course, limited by those who have internet access and those who have the ability to be able to connect using digital means. And so that is something, that is an inequality that existed before this pandemic. There are many, and it needs to be addressed so that we can reach more people everywhere. Our trainings are translated into 50 languages and also sign language. But again, we're trying to make sure that the guidance and advice that we produce is used by people in country. It's adapted and tailored to people in country to be most useful for them to keep them safe. A couple of last points before I end. We have a lot of challenges ahead. So much of the world remains susceptible to infection. The global situation is incredibly fragile. We have a two-track system that's happening right now in this pandemic. Many people in wealthier countries think this pandemic is largely over, but it's far from over. With the emergence of variants, which will continue to emerge, that are more transmissible, that have the potential to evade our public health and social measures, our diagnostics, our therapeutics, and our vaccines, it remains fragile. Our ability to control this virus remains fragile. So far, the variants of concern, including the Delta variant, are the public health and social measures, the diagnostics, the therapeutics, and the vaccines work. There may be some reduced efficacy for the Delta variant, but they still protect against severe disease and death. And this is really important. If your vaccine course calls for 2 doses, please make sure you get those 2 doses. When it's your turn, get your vaccine and advocate for the sharing of vaccines to your leaders, to those who need them most around the world. We have challenges with the implementation of public health and social measures. The use of them is inconsistent. It's very difficult to keep in place very stringent measures for long periods of time. It has a significant impact on people's mental health, on people's ability to earn income, and on society. And so we need to make sure that we use them appropriately. They're supposed to be tailored, targeted, time-bound, and linked to the intensity of spread. And vaccine, of course, still remains uneven and inequitable, and this is something that must change. Our health systems remain significantly under pressure, including healthcare systems, our burden on health workers, on global supplies, which is still not sorted. There's been a lot of work that has been done to source supplies, and to make sure that those reach everyone around the world, but it's still not completely fixed. Our surveillance systems are stretched. Our contact tracing systems are stretched. And this is causing challenges in terms of our ability to control. Our communities remain under-engaged and under-empowered. And this is a significant issue to be able to have everyone around the world be part of this fight. But we can't just tell people what to do. We need to discuss, we need to listen, we need to empower. And we need to understand the reasons why certain measures are not being adhered to. And the inequities that existed before this pandemic are prolonging the impact and the duration of this pandemic. Make no mistake, if we had used the 2.6 billion doses of vaccines equitably and among those who are most at risk around the world, we would be in a very different situation at this pandemic at the present time. So we need to acknowledge that and make some course corrections. And just lastly, we need to follow through and stay the course. And so our objectives remain the same: reducing exposure, suppressing transmission, protecting the vulnerable, and reducing morbidity and mortality. No one needs to be dying from COVID-19. We have the tools at hand: early clinical care, early oxygen evaluation, and use of dexamethasone for severe and critical patients. We can save lives now, and vaccines will only help that even further. Our priority actions are listed here, and I've already gone through them. But we really need to stay the course. We need to strengthen our systems. We need to use the trauma that all of us are in now to make the systems better for the next one. And I'm really worried that we're not doing that. If we wait until this pandemic is over, we will miss that opportunity, because preparedness, it doesn't start or end. It's a constant. And there's no peacetime. I'm sorry to say there's no peacetime. Managing pandemic risks is a constant. And the more we do, the more investment we have in preparedness, the better we will be to be able to quickly activate our systems and really enhance them where needed. So thanks very much for the opportunity to speak with you today, and I hope that was helpful.
Maria, that was absolutely wonderful. So an outstanding overview of the current status of the pandemic. A huge thank you. And I know you're going to stay around because we've invited a very good friend of us both, Devi Sridhar, who's in Edinburgh, where she's the professor of global public health at the university, to make a few reflections on your talk, and then we'll move. I should say the questions are flooding in, so we'll invite Devi to make her comments, and then we'll move into a Q&A, so that we answer the hot topics which folk are raising. So Devi, a huge welcome, and please just make a few comments around what we've heard from Maria.
Yeah, no, thank you, Andrew. It's great to be here, and I'll try to be short because I know there are a lot of questions, and I'd rather hear from the rest of the panel than be spouting off for too long. So I really just wanted to make 5 reflections listening to Maria. And the first is a huge thank you to her and the entire team at WHO for serving us through all these months. It's been quite easy to shoot the messenger, which is to target people personally for unhappy messages or things evolving. And so I think it's just worth reflecting on the personal toll it takes on the scientists at WHO who have had to manage this for months. I mean, they started these briefings in early January, and the service they do actually for the betterment of humanity. And I think that's something we can reflect on, because we're also seeing that in the United States with Dr. Fauci being targeted, but it's across the world, I think, kind of the attack on science because people don't like what science is saying. The second point I wanted to make was around the role of WHO, because many people don't understand what it can and can't do. And with a health emergency like this, it can really do 3 things. It has a normative role, a technical role, and a cooperation role. So normatively, we have the international health regulations, which are our legal instrument for how we respond to outbreaks. And according to that, WHO has been according to the books. It moved really quickly. So a memo was sent out early January by the WHO. It had been alerted by China to a new cluster all countries got that memo. And that was the moment you wanted to start running or not. And countries that had experience with other coronaviruses immediately got very nervous, or those who worried about what this could mean and started running. Taiwan, Hong Kong, Singapore, South Korea. Others waited and watched. And then 30th of January, they, had the emergency committee convene for a second time and said, this is an emergency. And that's the alarm bell. That's the highest level of panic in a way they can say to the world, you got to run. People focus on March for the pandemic designation, but pandemic is not actually a legal term. It's actually the public health emergency of international concern. So it was really January 30th when they said, wake up to the world. You might ask, why didn't they say this earlier? But you have to remember, every month they're getting hundreds of signals from across the world. Of those, they have to determine which are going to become serious events and which can be managed locally or domestically. So you may not have heard about yellow fever or plague or Zika virus or, all these viruses that are emerging in different places, but don't end up being global emergencies. The second role is technically to share information. And again, from early January, I remember listening to Maria and Dr. Mike Ryan all the time giving these press briefings, and they gave all the information. So if you were listening to them by the end of January, you knew a lot about this virus, how it was spreading. All the information was there. You just had to listen every day. And then you had in February the technical mission that went to China by Bruce Aylward. And again, I listened to that briefing and you got a lot of information. If you go back and reread that February report, there's enough in there to understand how China stopped transmission, what lessons there could be for other countries, as well as the epi profile of who this was affecting and the clinical need. So I think there they've served their role well. The third is on cooperation, and here you've had COVAX, the facility for vaccine sharing, and WHO tried to get ahead of this. They had their May resolution at the World Health Assembly, May 2020, where they said to countries commit to sharing. All countries agreed to that, including the WHO, the United States under a Trump administration, despite them not being happy with that. They agreed to the sharing, but it's one thing to have countries agree to it on paper and say to WHO, yes, we will do this, and another thing to actually do it, as we're seeing with COVAX and vaccine sharing now. So I guess in those three roles, I actually am quite sympathetic to saying it's gone pretty well in terms of what they actually are able to do. Though people often say, why didn't they do this? Well, they can't go in and investigate because they don't have, they're not like a weapons inspector who can go and investigate facilities. They have to be invited by countries and negotiate that. The third point I wanted to make is, has WHO got everything right? And of course, as Maria said, no, they haven't. They haven't gotten 100% right. But the truth is, none of us have. I think all of us who have been working on this from the start would look back and say, we've had to evolve our thinking because science has changed and the data has changed. And so in a way, it's obviously hard when you're in the media or you're doing daily briefings because people can pull back out what you were saying at the start and then come back and kind of rehash it. And so I think, for example, of, a professor in Australia, one of the foremost experts on virus spread, and he told me that he wrote an op-ed for the New York Times in early January saying, don't panic, this is not going to become a pandemic. And he's so happy the New York Times didn't publish it, and there's no proof of that because he said, I've worked on this for years, but there's such uncertainty at that point. And I think that uncertainty is what it's been hard to communicate to people. So examples over uncertainty. First, vaccines. If you talk to the foremost experts on vaccines, or even someone again like Dr. Fauci, they were saying a vaccine, no way within a year. We didn't have one to other coronaviruses. It just seemed, yes, we should try, and hundreds started running. But for anyone to say, oh, we're definitely going to have a vaccine would just be implausible. So again, we've managed a vaccine, but there was uncertainty. Second, around face masks. At the start, should we have told everyone to wear face masks? I can admit myself, I was not telling people in January to wear face masks in Britain because first there was PPE considerations. Health workers didn't have enough, so it felt selfish to be asking people to wear them, outside on the street when, health workers don't have them. But also we just at that point didn't understand, is actually this needed at this point? And again, it's easy afterwards to say, well, what not? We didn't move fast enough, I don't think, in certain parts of the world to get face coverings, but it wasn't clear from January that everyone needed to be wearing these, and that's what we should be recommending. Another one is around variants. I think the hope was that this would become a more transmissible, more innocuous virus. So this would mutate to a milder form. So there's always the idea that there would be mutation. But I think some of the uncertainty was what kind of mutations would occur. And unfortunately, what we've seen with Delta is mutations to be more transmissible and more severe from the emerging data in Britain around more hospitalizations. So again, we could kind of predict mutation, but you couldn't predict which way it would necessarily go. We knew more transmissible, but there was always this kind of hope that it would actually be a milder version, not a more severe version. And I think a final one is around children. Coronaviruses usually affect children and circulate quite easily among them. The original SARS-CoV-2 didn't seem to do that. So in a way, we were quite worried about kids at the start, but then not worried because the data from China said children are relatively unaffected. And then now we're seeing new variants. And every time there's a new variant, you have to race to figure out, like with Alpha or B117, is this going to change the advice on children in schools? Delta, is this going to change the advice on children in schools? And that's not backtracking. It's actually evolving what you're saying to countries and giving your advice. So the fourth thing I wanted to say is that, there's always this feeling of, oh, it could have been so much worse. But I actually, and I'm curious what Maria thinks, but I think COVID falls into disease X. I think actually it hit that sweet spot where because of the combination of very mixed outcomes, largely affecting vulnerable older people, the death rate kind of between, 0.5%, but it can go up higher, if there's no medical care. So it's not like MERS, which kills, what we see like a third of people. It spreads, pre-symptomatically, so people can be fine and walking around and mixing and then all of a sudden get unwell. And then just the personal, the age dimension as well. So I actually see this as being really difficult for countries from a public policy point of view, because it kind of is not as innocuous as seasonal flu, but it's not as dangerous a pathogen as Ebola or MERS. And so in some way, it would be easier if it had been one or the other. Then you could have said, okay, we have to live with it, mitigation, it's a seasonal flu, or we have to run towards elimination because we can't live with this. Or if it was killing off kids in the way it affects those over 60 and over 50, if it was reversed, that kind of age gradient. So I actually think in some ways it was harder to get public consensus and ministers behind one agenda because of that kind of sweet spot it hit between, it's kind of like the perfect virus if you wanted to kind of put one on Earth to have it spread, because of kind of falling between stools. And also people's personal experience with the virus can be so different from being asymptomatic to actually dying from it. And the final thing I want to mention is around vaccines and how we prepare for the next one. Because right now, the biggest problem for the world is not enough. I would say it's not enough vaccines to go to all places. And Maria's talked about that inequality and why we have people dying, healthcare workers dying, and now especially in Africa as the wave starts to head off and we end up with in some way two pandemics, one in the rich world, which is slowly coming not to an end, but actually becoming manageable, and one in, other countries which managed the first wave, managed the original one, but now have Delta, and they just can't keep that suppressed. And so their health systems are going to be struggling, and hopefully we won't see India repeat, but I think we will now see those scenes we've seen in India repeat in other countries. But I think it's very predictable we see it. I don't think you can ever say to rich countries, share, when they feel like they need it more. I think politically it's just so difficult, and we've seen this, even with a very progressive president and Joe Biden in the United States saying, we've got to take care of Americans first. We'll take care of the world, but Americans first, because they see that as their responsibility, especially when you've had, rich countries under lockdown measures and people feeling like they've suffered and had quite high death tolls through that. So I think looking forward, for me, the issues are how do we prepare, as Maria's saying, for the next one? Where are the stumbling blocks? And I think one is around, manufacturing capacity. Dr. John Akengason, the head of the Africa CDC, talks a lot about Africa having to be self-reliant, actually having the manufacturing capacity to make the mRNA vaccines, or to make enough, having enough flu facilities to switch from seasonal flu to pandemic flu. And right now, that's not the way manufacturing happens. We don't have regional hubs. It's actually concentrated. I think the second thing is around IP and loosening IP during emergencies. So when is it appropriate to say that actually we need to loosen it to be able to have this, be everywhere? When has enough profit been made by, big pharma companies? And we say, okay, you've made your profit, you've made your shareholders rich. Now we need to move on to the humanitarian emergency and getting ahead of that. And I think the third thing is around supply chains. We've seen problems that even if you have the factory, even if you have the know-how, even if you have the IP waiver, if you don't have the supply chains of all the kind of raw materials you need, then you're stuck. And I think they're reaching, again, how do we actually get those supply chains in order ahead of time? There's a hard business case to be made there because nobody wants to invest in, factories when we don't know when the next pandemic will be, and actually will they make a profit from this? So that's a bit of the difficulty. I think it's actually a private sector kind of limitation to saying, do we want to do this? Is the profit margin large enough for something, let's say, like pandemic flu or new pathogen? So I think looking ahead, I just stopped there, but those are kind of listening to Maria, the reflections I had looking ahead of where we are now and where we're going into the future. So I'll stop there, Andrew.